Hello everybody. Today we are going to discuss the question which was asked in DRNB Critical Care Examination 2020, that is refractory and super refractory status epilepticus. So we'll see what is definition of the status epilepticus. Status epilepticus is medical emergency which is defined as tonic-clonic convulsion lasting for more than 5 minutes or occurrence of two or more sequential seizures without complete recovery of consciousness between the two episodes. Refractory status epilepticus is the status epilepticus that persists despite treatment with initial IV benzodiazepine and second longer acting IV anti-seizure drug. Super-refractory status epilepticus is defined as status epilepticus that continues 24 hours or more after onset of anesthetic therapy, including those cases that recur on reduction or withdrawal of anesthesia. About one-fifth of the patient with refractory status epilepticus go on to super-refractory status epilepticus. Now, what is new onset refractory status epilepticus? It is defined as a clinical presentation, not a specific diagnosis. In a patient without active epilepsy or without other pre-existing relevant neurological disorder, or new onset refractory status epilepticus without clear acute or active structural, toxic, or metabolic cause. So, febrile infection related epilepsy syndrome is a type of new onset refractory status epilepticus, which is characterized by a febrile infection that occurred between 2 weeks to 24 hours before the onset of refractory status epilepticus. So, febrile infection may or may not be present during the onset of status epilepticus. So, most seizures cease spontaneously, but some progress to longer seizure or status epilepticus will transition to prolonged seemingly self-sustained seizure or status epilepticus appearing to depend on relative balance of excitatory and inhibitory electrochemical function at cellular, subcellular and extracellular level. Early in status epilepticus, there is marked and progressive impairment of GABA agonist mediated inhibitory function. This correlates with the loss of GABA receptor on neuronal surface, in large part due to progressive internalization or endocytosis of this receptor. Around the same time, there is increasing excitatory activity of glutamate receptor during status epilepticus, especially N-methyl D-aspartate and alpha amino 3 hydroxy 5-methyl isoxopropionic acid, that is an AMPA receptor promoting hyperexcitable state. As this progresses, seizures appear to become resistant to many anti-seizure drugs, especially those acting through GABA system, including benzodiazepine and barbiturates. Those receptors, however, may remain sensitive to other drugs, suggesting potentially useful agent for the treatment of refractory status epilepticus. These physiological alterations in the neurotransmitter activity occur very early in the course of status epilepticus, within minutes, and providing incentive for early escalation to definitive treatment to avoid such a pharmacoresistance. There is also clear evidence experimentally and some clinically that status epilepticus becomes harder to interrupt the longer it lasts. The same excitatory process appear to be involved in neuronal injury during prolonged status epilepticus, with potential injury depending somewhat on intensity of epileptiform discharge. Generalized clonic status epilepticus also endangers major physiological changes, which may contribute to its potential for morbidity and mortality. These physiologic consequences may in turn have direct harmful effect on brain and some mediated by excitatory neurotransmitter toxicity and some via inflammation. Clinically, there are well-detailed cases of severe and permanent neurological damage, such as hippocampal gliosis and atrophy, reasonably attributed to prolonged status epilepticus alone. Imaging studies, including CT, MRI, PET scan, have shown substantial changes in the brain tissue with status epilepticus, but the clinical implication can be uncertain. So, mortality from the status epilepticus is about 5 to 25% overall, depending on the cause and the population studied, but substantially higher for refractory status epilepticus and super-refractory status epilepticus. In one meta-analysis of treatment with refractory status epilepticus with aggressive therapy, the overall mortality was 48%. Super-refractory status epilepticus is usually associated with mortality rate of over 30% and with over 50% of patients dying or in vegetative state in cases of new onset refractory status epilepticus. Considering both mortality and morbidity, under one-fourth of all suprarefractory status epilepticus and new onset refractory status epilepticus patients reported so far have had good outcome. Most survivors had significant residual impairment. Good outcome is reported in case of refractory and super-refractory status epilepticus. Now, this is the treatment line which we are using for treating refractory status epilepticus. So, we can use midazolam in the dose of 0.2 to 0.4 mg per kg minutes until seizure control. Maximum dose is 2 mg per kg. Then maintenance infusion rate of 0.1 to 2 mg per kg per hour. Adverse effect are respiratory depression and hypotension. Then the next drug is propofol, that is 2 mg per kg IV every 5 minutes until seizure control. Maximum dose is 10 mg per kg. Maintenance infusion rate is 30 to 200 mics per kg per minute. Avoid if more than 80 mics per kg per minute for more than or equal to 48 hours. Adverse reaction is hypotension, propofol infusion syndrome. Then pentobarbital. The dose is 5 mg per kg IV up to 50 mg per minute every 5 minutes until seizure are controlled or maximum loading dose of 15 mg per kg. Maintenance infusion dose is 0.5 to 5 mg per kg per hour. Adverse effects are hypotension, adynamic ileus, respiratory depression, hepatotoxicity, and prolonged sedation. The first drug that we are used, now we'll see each and every drug in detail. So midazolam. Midazolam acts as an agonist as GABA A receptor, penetrating CNS rapidly with fast onset of action, typically in minutes. It is a short acting with half-life of 0.8 to 2.8 hours, making it ideal for avoiding toxic accumulation. Caution should be taken in obese patients in whom where accumulation occurs in adipose tissue and those with renal insufficiency. So midazolam infusion can be associated with tachyphylaxis, necessitating gradually higher doses. So hypotension requiring pressure occurs in 30 to 50% of patients. So midazolam is the respiratory depressant and infusion often require intubation and mechanical ventilation. So propofol is the potent IV anesthetic that act as CNS depressant through direct activation of GABA receptor and inhibition of the NMDA receptor. So propofol has rapid onset of action and decreased cerebral oxygen utilization quickly, thus reducing intracranial pressure. Hypotension necessitating the use of pressor occurs in 22 to 55% of patients with propofol infusion. The worrisome complication is propofol infusion syndrome, which is a result of toxic effect on mitochondrial function and cellular function, causing metabolic acidosis, rhabdomyolysis, renal failure, triglyceridemia, refractory bradycardia, and cardiac failure. So this propofol infusion syndrome may be avoided by using propofol limiting its use to 2 to 3 days and at doses not exceeding 80 mics per kg per minute. So, when propofol infusion syndrome occurs, the treatment is supportive and including discontinuation of propofol along with cardiac, pulmonary, and renal support. The next is barbiturate. Thiopental and its metabolite pentobarbital have strong anti-seizure effect. Their main mechanism of action is by augmenting transmission at GABA A receptor. They also lower body temperature and may be neuroprotective effect. In high doses, they can cause loss of brainstem reflexes and isoelectric pattern on EEG. So barbiturates are almost always successful in achieving seizure control, but due to their prolonged duration of action. However, the regaining of normal alertness is delayed significantly, so they are not usually first-line treatment. Prolonged recovery times and the longer duration of mechanical ventilation due to its zero-order kinetic and rapid redistribution and accumulation. So barbiturates are metabolized by liver and have many drug-to-drug interaction. So hypotension requiring pressors occur in 29 to 77% of patients treated with barbiturate for refractory status epilepticus. A relative common adverse effect is adynamic ideas occurring in up to 10% of patients, which can lead to bowel ischemia and even perforation. In less than 1% of patients, propylene glycol toxicity can manifest with acidosis. Infrequently, lingual edema develop and can compromise the airway. The latter two complications are treated by stopping the drug. Then choice of drug. There is insufficient evidence regarding the choice of drug, duration of therapy. The optimal electroclinical goal of treatment, that is simple cessation of seizure, both clinical and electrographic seizure controlled, or certain degree of suppression of cerebral activity as assessed on EEG, often to burst suppression pattern, has also never been studied well prospectively. So it remains unclear what is best. Now, EEG monitoring during aggressive treatment. Status epilepticus persists in the non-convulsive form in 14 to 20% of patients after cessation of clinically evident seizure. And clinical signs of status epilepticus are non-specific, subtle, and non-existent. So, of 164 patients who had apparent control of clinical status epilepticus in one series, 42% had continued epileptic from discharge, and 14% were in non-convulsive status epilepticus. So, failure to recover may be explained by electrographic persistence of seizure activity, which most epileptologists consider continuation of generalized clonic status epilepticus and warranting urgent treatment. For ICU patient with diminished responsiveness, non-convulsive status epilepticus is remarkably common, especially if there were earlier generalized convulsion. In patients with coma of all causes, 8% have non-convulsive status epilepticus in another series. In patients with persistent impaired mental status, EEG alone can distinguish those in drug-induced coma from those who are post-ictal and from those with continued non-convulsive seizure. During prolonged IV infusion of anti-seizure drug, continuous EEG is essential to assess effectiveness of treatment for duration, for detection and recognition of recurrent seizure and status epilepticus, and in managing their retreat. Continuous EEG recording should be initiated as soon as possible after diagnosis of status epilepticus, optimally within 1 hour. So during treatment, EEG should be reviewed immediately and then periodically until status epilepticus has been controlled or burst suppression record is induced. Once seizures are suppressed, less frequent review may be sufficient. Persisting seizure require more intensive monitoring. Optimally, the EEG monitoring should be performed and reviewed from time aggressive therapy started until seizure stopped and patient has returned to normal consciousness, or at least until all seizures are controlled for 24 hours. Status epilepticus recurs. The diagnosis of recurrent seizure or ongoing non-convulsive status epilepticus on EEG relies on the determination by clinical neurophysiologists that certain patterns are biictal in nature, that is signifying ongoing epileptic seizure. But there is substantial controversy regarding which EEG pattern are indicative of seizure. So, American Clinical Neurophysiology Society research criteria for non-convulsive seizure is repetitive generalized focal spike, polyspikes, sharp wave, spike and wave, sharp or slow wave complex, and other rhythmic waveform at 2.5 per second, lasting for longer than 10 seconds, or the same waveform above with discharges less than 2.5, but with clear clinical ictal phenomenon such as facial twitching, nystagmus, and limb myoclonus. An unequivocal evaluation of the rhythmic pattern, including increase or decrease in frequency by more than 1 Hz, change in discharge morphology or in location. So, change in discharge amplitude or sharpness alone is not sufficient. Or rhythmic delta wave at more than once per second with additional criteria of unequivocal clinical improvement or improvement of EEG or both following quickly after acute administration of rapid acting anti-seizure drugs, typically benzodiazepine. Now the treatment of relapse. Treatment decisions are generally extrapolated from trials of generalized clonic status epilepticus. So, treatment or tailored to perceived urgency and morbidity of the seizure and status epilepticus encountered in the eyes. When status epilepticus recurs clinically or electrographically, most neurologists intensify treatment sometimes by restarting or increasing the doses of midazolam, pentobarbital, and propofol. Sometimes using this infusion for longer and adding more non-sedative drugs or effecting higher levels of prior anti-seizure drug and and continuing aggressive therapy for 24 hours before attempting another taper. Alternatively, some might try non-sedative drug first, resorting to aggressive therapy if they fail. So, at this retreatment can lead to long ICU course, and it may be necessary to tolerate occasionally brief seizure to help get the patient out of the ICU. Complication of aggressive treatment of refractory status epilepticus. Prolonged treatment of status epilepticus with heavily sedative medications such as midazolam, pentobarbital, and propofol can result in hypotension or prolonged mechanical ventilation and is associated with worsened outcome, usually attributed to severe underlying illness causing status epilepticus. So, etiology of status epilepticus is overwhelmingly most important prognostic factor. Short-term mortality is highest when status epilepticus result from acute insult, especially stroke, infection, or anoxia. So, patient with multiple medical problems, including sepsis, fare poorly with those with status epilepticus due to trauma, alcohol abuse, or other drugs have intermediate or lower mortality. The most favorable etiology is epilepsy itself, with some exacerbating factors prompting status epilepticus. Presentation in coma confer poor prognosis, but this may also be related to severity of etiology. So, although the etiology is key, one study found that death following status epilepticus appear unrelated to etiology in about 10% and may have been caused by complication of the treatment or prolonged ICU stay in coma. We recommended that most patients with refractory status epilepticus and super-refractory status epilepticus, including those with generalized status epilepticus or other non-convulsive status epilepticus that follow generalized clonic status epilepticus, be treated aggressively with continuous infusion of midazolam, pentobarbital, and propofol. Most other type of refractory status epilepticus, however, should not be so treated unless the status epilepticus is particularly long and refractory and the patient and neurologist accept the possible complication of such a treatment. Then other type of the refractory status epilepticus. Typical absence status epilepticus that occur within absence epilepsy or arising in other primarily generalized epilepsy syndrome is relatively uncommon and almost always interrupted readily. With increased doses of patient earlier anti-seizure drug, modest doses of benzodiazepine, or addition of other non-sedative ASD, particularly IV, but sometimes effective even orally. Absent status epilepticus almost never become refractory. It has excellent prognosis and aggressive therapies should almost always be avoided. The outcome of complex partial status epilepticus depends primarily on the etiology. Morbidity often derived from the unresponsive state and from complication of underlying illness rather than from a complex partial status epilepticus itself. Some patients had prolonged memory and other cognitive deficit following non-convulsive status epilepticus, but many of these resolved eventually. Prolonged complex partial status epilepticus had clearly been associated with serious morbidity, but most of these patients had significant underlying lesion, that is a stroke or encephalitis, causing complex partial status epilepticus and is likely contributing substantially to the later deficit. Now, the next terminology is epilepsia partia continua. The continued focal jerking of epilepsia partia continua is often refractory to anti-seizure drug. That is valproate, clonazepam, levetiracetam are common treatment. Topiramate and levetiracetam can be used. For this epilepsia partialis continua of Rasmussen encephalitis, intravenous immunoglobulin and plasma exchange are used increasingly. Resective surgery can be curative if lesions are small enough. Larger resection, corpus callosectomy, multiple subfield transaction can be useful in selected cases. Epilepsia partialis continua may also resolve without treatment. So epilepsia partial continua can be refractory and anti-seizure drug may be help prevent dangerous secondarily generalized convulsion, but especially with preserved consciousness, it should very rarely be treated aggressively. There are many forms of myoclonic status epilepticus. May occur in primarily generalized by idiotopic epilepsy syndrome. Several include prominent eyelid blinking with low amplitude, multifocal jerking. A few of these syndrome include generalized convulsions, but some do not cause significant alteration in consciousness. This myoclonic status epilepticus very seldom become refractory, even when including convulsion, and aggressive treatment is almost never needed. Now, anoxic myoclonic status epilepticus is entirely different. Most cases are fatal. Therapeutic hypothermia has led to some improved outcome, but after few days of anoxic coma, the outlook is almost always grim, especially if refractory status epilepticus occur on age. Then similarly, this myoclonic status epilepticus due to medical problem, such as major organ failure and metabolic derangement, is often associated with coma, and the prognosis depends on underlying medical illness, sometimes reversible. It is very unusual that patients with this form of myoclonic status epilepticus should receive aggressive treatment. Rather, treatment should focus on underlying cause. Now, non-sedating drug in treatment of refractory status epilepticus. So, as for patient with refractory status epilepticus who had never had definitive convulsion There should be vigorous attempt to interrupt and keep seizure suppressed with one or more non-sedating anti-seizure drug. Among many choices are IV phenytoin, fosphenytoin, phenobarbital, valproate, lacosamide, levetiracetam, enteral topiramate, carbamazepine, and other standard AST without IV formulation and various form of stimulation, diet, and even surgery. Avoidance of intubation should be the priority. Now about super-refractory seizure. Aggressive and other treatment are usually successful in treating all, but most refractory status epilepticus. For some super-refractory status epilepticus, however, it may become clear after several days that course is not going well and will be specially prolonged. So the expediting ICU stay with the patient with super-duper refractory status. We need to consider some new treatment in this case scenario like immunotherapy, ketamine, surgery, ketogenic diet, and various type of stimulation. Consider prolonged phenobarbital and lorazepam. Convert covered withdrawal of highly sedating drugs. Then try non-sedating ASD first, and when treatment must be intensified for relapses. Assured adequate doses of concomitant non-sedating ASD and highly sedative drugs. Surveillance for and management of infection, hematological problem, and organ failure. Tolerate a few seizures per day, especially if non-convulsive or focal or brief and not generalized convulsion. Do not increase the treatment for isolated and non-rapid periodic epileptiform discharge. About immunosuppressive therapy. Encephalitis and autoimmune disorder. After few days of aggressive therapy for refractory status epilepticus, immunotherapy is often considered. Indeed, if presentation suggests recognizable autoimmune syndrome, it should be begun at the onset. Many of the most refractory cases of status epilepticus seem to occur in young adults who present with new onset refractory status epilepticus, which often appear to have inflammatory or autoimmune etiology. Clinical clues that refractory status epilepticus patient has one of these autoimmune syndrome include subacute onset, high seizure frequency, seizure variability and multifocality, anti-seizure drug resistance, history of cancer, personal or family history of autoimmune disease. Other are gradual cognitive impairment, neuropsychiatric symptom, multi-level nervous system involvement, new onset movement disorder. The detection of neural specific autoantibodies in serum and cerebrospinal fluid can help to establish the diagnosis. Testing abnormalities suggesting one of these illness include evidence of inflammation on MRI, FDG PET, and in the CSF. NMDA receptor encephalitis was first described in young female with ovarian teratoma but can occur in patients without tumor, including men and children. The classic presentation is with like viral-like prodrome, followed by psychiatric disturbances and often orolingual and facial dyskinesis, seizure, and later central hypoventilation, autonomic dysfunction, and coma. Voltage-gated potassium channel modulate neuronal excitability, axonal conduction, and neurotransmitter release in the central, peripheral, and autonomic system. LG1 and Caspr2 are the two antigenic target in potassium channel complex. LG1 antibodies are frequently associated with limbic encephalitis and Caspr2 antibodies with peripheral nervous system manifestation, but both can affect all the levels of the nervous system. Up to 50% of patients with VGKC associated encephalitis have MRI evidence of inflammation and cell loss with enlargement and T2 hyperintensities enhancement and restricted diffusion in mesial temporal structure. So the seizures often have focal onset. There are other autoimmune syndrome with different antigen association, including anti-GAD and anti-U. Treatment of NMDA, VGKC, and other autoimmune encephalitis causing refractory status epilepticus include Immunotherapy with high dose IV steroid alone or with IV immunoglobulin and plasma exchange. If first line therapy fails or is insufficient in antibody mediated, proven or suspected case of autoimmune based refractory status epilepticus, then rituximab or cyclophosphamide can be considered and offer effective. These treatments are mandatory for clearly diagnosed cases of autoimmune cause refractory status epilepticus, but with less certain diagnosis with possible benefit must be weighted against the serious risk of infection in long-term ICU patients. The next modality of treatment is ketamine. As seizure progress, both in experimental animal and in human studies, they appear to become resistant to many AST, especially those acting during GABA system, such as benzodiazepine and barbiturates. So, NMDR antagonists are of limited value in blocking the initiation of status epilepticus. But seizure continue, they appear to become more effective, and glutamate antagonists, such as ketamine, may become helpful. So ketamine is anesthetic drug with the action as NMDA receptor antagonist used in treatment of status epilepticus, which is refractory to drug acting at GABA A receptor. It has rapid onset of action and is relatively short acting with elimination half-life of 2 to 3 hours. An attractive feature is that rarity of associated respiratory and cardiac depression. Sometimes supraventricular tachycardia is reported. Long-term adverse effects of ketamine are not well understood. Unfortunately, under 10% of patients had good outcome, but ketamine was probably the final of many treatment for prolonged refractory status epilepticus and thus less likely to rescue the patient. This report discussed the possibility of barely use of ketamine, which is certainly plausible for earlier stages of refractory status epilepticus, but its long-term effects are less well understood and it is less familiar to the most neurologists. Then the next treatment of line is ketogenic diet. Ketogenic diet is high-fat, low-carbohydrate and adequate protein diet devised to mimic fasting state and produce ketosis. It can be effective for patients with drug-resistant epilepsy adverse reaction, included hypertriglyceridemia and transient acidosis in both studies, resolving with the cessation of ketogenic diet. So about two-thirds of patient had resolution of uh, this super refractory status epilepticus in 3 to 5 days after ketogenic diet initiation with subsequent withdrawal of highly sedating medication. So ketogenic diet appear to be safe and reasonable treatment for adult with refractory status epilepticus and super refractory status epilepticus. So problems include that it can be difficult to use, requiring professional dietitian help, avoidance of many infusions that include carbohydrate, especially in ICU, and 2 to 3 or more days required to reach ketosis. Then the next line of management is neurosteroid. Allopregnolone is the endogenous metabolite of progesterone. It is an allosteric modulator of synaptic and extrasynaptic GABA receptor, making it plausible treatment for refractory status epilepticus and suprarefractory status epilepticus, even when the cause is not necessarily inflammation and immune based. In clinical trial, allopregnolone was safe and tolerated well by patients with very refractory status epilepticus and appeared to help wean the therapeutic coma induced by heavily sedating medication without status epilepticus recurrence. A phase 3 randomized double-blind placebo-controlled trial, however, failed to show that it was better than placebo plus standard treatment for such a week. Then stimulation. Repetitive transcranial magnetic stimulation is a relatively new non-invasive technique for treatment of seizure and status epilepticus. At lower frequency, the repetitive transcranial magnetic stimulation can suppress cortical activity, but at higher frequency, it can cause cortical excitation. There are few case reports of its use in refractory status epilepticus. In 1-2 ICU patient, with refractory focal status epilepticus had at least 50% reduction in the seizure frequency after repetitive transcranial magnetic stimulation application. To date, cases are too few to provide evidence of efficacy, but repetitive transcranial magnetic stimulation appear to be very safe and do not require surgery or device implantation and do not require cessation of earlier anti-seizure drug. Adverse effects include inducing seizure or headache and dizziness. Its use may be restricted to epileptogenic foci close to cortical surface because magnetic stimulation effect falls off rapidly with distance. Now, the next line of management is surgery. Surgical intervention can help for patients with particularly refractory focal status epilepticus. In one series of 10 children with focal status epilepticus refractory to at least 2 weeks of high dose suppressive therapy, status epilepticus was terminated by resection of epileptogenic zone in all, and 7 out of 10 become seizure free. Other helpful procedures have included wider lobar or even multilobar resection, even to the point of functional and anatomic hemispherectomy, disconnection procedures such as corpus callosectomy, multiple subpial transection with or without focal resection. Thank you, guys.